So John, tell us what's the criteria for resectability? So you mentioned surgeons play different roles, both in early and late stage disease, and it's a unique role for surgeons.
Right.
So how do surgeons play that role, and what sort of factors come into play?
Right. So, you can think of it as stage 4 versus not stage 4. So in early stage disease, of course, surgery should always be considered. As we said, sometimes for really small indolent tumors, a watch and wait approach can be taken. That's usually not the approach for small bowel nets, which tend to be malignant even if they're slow growing and even if they're small. But an option sometimes for pancreatic nets. For rectal nets that are very small and superficial, sometimes endoscopic management is sufficient. But for most early stage tumors, we're talking about surgery. But then for stage 4 disease, we also think about surgery. And we think about it primarily in well-differentiated, usually more in low-grade tumors than intermediate-grade tumors. The standard criteria is if it looks like at least 90% of the metastatic disease can be resected. And typically we're talking mostly about the liver rather than other organs such as peritoneum or bone. We also need to think about resection of the primary tumor, even in patients with stage 4 disease, because these patients can continue to have problems related to the local site, such as obstruction or bleeding or pain in the case of, for example, small bowel neuroendocrine tumors. And so very often in patients with metastatic small bowel nets, we'll recommend resection of the primary tumor. We do that much less for pancreatic nets, particularly if it involves the head of the pancreas. I think the data is a little bit more controversial. And of course, all the data is non-randomized and retrospective, which makes it hard to talk about these recommendations with a high level of certainty. But still, I think that the evidence suggests that long-term outcomes are good if most of the disease can be resected. Any other thoughts on that?
No, I think, we're constantly understanding the role that our surgical colleagues can play. And I think the role of debulking surgery is very important. Right. I think for many patients, it can range from anything from helping their hormonal secretion and improving their quality of life to literally turning back the clock and slowly bringing that back. And I think they're an integral part of the discussion is to understand the role surgeons can play. I think as I think you alluded to, I think one of the big questions I think my surgical colleagues are struggling with, and is, what do we do with incidental rectal nets when we find them? How do we excise them? How do we follow them? And what is the need for that? And the other thing would be trying to understand for those smaller pancreatic neuroendocrine tumors, what patients are the appropriate ones to follow and potentially avoid a big surgery like a Whipple's. Yeah.
And we haven't really talked about gastric nets, but that's a really interesting and poorly understood entity. The large majority of gastric neuroendocrine tumors, the type 1, are actually just small multifocal polypoid lesions that are associated with atrophic gastritis, in which the atrophic gastritis leads to a low acid state, and then the antrum produces high levels of gastrin stimulating these tumors. This is almost never a surgical circumstance, although sometimes we see patients inappropriately referred for surgery. The standard treatment is surveillance and endoscopic resection. Type 2 is a little bit more complex. Those are gastric nets associated with gastrinomas, where the gastrin produced by the pancreatic or duodenal gastrinomas is leading to these small gastric nets, and I won't get into that because that's quite rare and complicated. And then type 3 are the sporadic gastric nets, which are typically managed surgically, although small ones can sometimes be managed endoscopically. But I think it's important for clinicians to be aware that there are these 3 types of gastric nets that are managed completely differently. What are your thoughts on the role that Gallium-68 Dotatate, the net spot, plays as far as selecting patients for surgery and for other treatments?
So I think this is one of the most exciting developments we've had in the past few years has been development of Gallium-68. Functional imaging or somatostatin receptor imaging is so important in neuroendocrine cancers. I think we're fully not quite, we don't have a full understanding yet of exactly the complete role that it can play and where it can have an impact. I think for my surgical colleagues, where it really can play a big role is helping them map out disease. So when they are doing surgery, they can make the appropriate decisions based on the possibility or the spread of metastatic disease, and also ensure that their surgery is as complete as can be on one go, rather than having to do repeat imaging. From our point of view, I think it helps us understand the biology of disease, it helps us classify the disease, and also helps us incredibly with staging, and as well as determine if some treatments such as PRRT or radioreceptor isotope therapy may be appropriate. I think all of that information is coming from one test. Is quite astonishing.
There have been some concerns sometimes that surgery, that the Gallium-68 Dotatate scan can inappropriately rule out surgery. So, for example, patients with resectable liver metastases that happen to have several small bone lesions, may be excluded from surgery, and perhaps inappropriately so.
I mean, I think this is like, what you're discussing is stage migration, really. And, as time goes on, this is going to be a phenomenon with every cancer, and other cancers have dealt with it as well, including, colon cancer, for example, with better lymph node sampling, et cetera. So I think, these are realistic questions, but I think we need to keep in mind that these lesions may have been in our patient series before. We just never knew about it. And I think that's where we're still working on trying to understand the optimal use of Gallium-68, both to help with surgery and also to prevent unneeded or unnecessary surgeries.